So please welcome Dr. Izzy Westling, who's going to talk to us about NAFLD.
Hi, everybody. Thank you for that introduction, Courtney. I'm Izzy. For those who don't know me, I'm one of the primary care R3s, and thank you for being here to listen to me talk about NAFLD, which is a topic that I greatly enjoy. I think largely because I felt a little bit underskilled to deal with it in primary care, and last year got to spend some time with Dr. Lauren Best in the VA hepatology clinic and felt like she gave me a whole bunch of knowledge and skills to help me be a better primary care doctor that I would like to share with you today. And full disclosure, I've tried to cram a lot of information into my talk, and so there are some natural break points during this talk where I think we can pause for questions, and I will deliberately pause there, but probably won't answer questions sort of as they come up as we're going through, just in the interest of trying to get through all of this information and not go over. So welcome to my talk on NAFLD for the primary care internist, and thank you for being here. So, disclosures, I have none other than a love of livers and no desire to be a gastroenterologist. My objectives for today are to help you appreciate the importance of making an early diagnosis of NAFLD, to learn to follow the appropriate diagnostic steps for ruling out other causes of transaminase derangements, to teach you to use the available tools to risk stratify your patients with NAFLD, and then to be able to counsel patients on lifestyle and medical therapies to reduce some of the sequelae of NAFLD. So here's our roadmap for today. First, we're going to talk about why we should care about NAFLD in the primary care setting. Then we're going to talk about making the diagnosis and ruling out other causes of transaminase changes. Then we will talk about how we risk stratify our patients once we feel confident in our diagnosis of NAFLD. And then last, we're going to talk about therapeutic options for our patients and hopefully have some tools for counseling. So let's start with why we care. So I think a good place to start is to talk about the NAFLD spectrum. So when we think about NAFLD, about 25% of adults in the United States have NAFLD when we sort of take all comers and do either liver biopsy or ultrasound. And NAFLD, or non-alcoholic fatty liver disease, to define this acronym that I'm going to keep using, is a spectrum of diseases that runs from fatty infiltration of the liver without any inflammation all the way to cirrhosis and hepatocellular carcinoma. So when we think about our 25% of adults who have NAFLD, that's 25% who have some amount of fatty infiltration with or without inflammation or scarring in their liver. And then of those 25% of adults, about 25% will have NASH, which is another term that you may have heard, and that is non-alcoholic steatohepatitis. And NASH is fat infiltration plus inflammation and potentially fibrosis and scarring in the liver. And NASH, just to be super clear about our terminology, is a histologic diagnosis that can only be made with liver biopsy. So unless you're biopsying your patient's liver, you actually can't say whether they have NASH or not. The most you can say is that they have NAFLD. And then of our patients who have NASH, about 25% will go on to develop cirrhosis as a consequence of that inflammation and fibrosis and scarring in their liver. And then some percentage of those patients with cirrhosis will develop HCC. And it's not super clear what percentage will go on to develop HCC, but it does seem like the percentage of patients who develop HCC as a consequence of NASH cirrhosis is maybe a little bit lower than the percentage who develop HCC as a consequence of Hep C related cirrhosis or Hep B related cirrhosis. So I think to sum up, there's sort of this big spectrum of NAFLD that runs the gamut from simple fatty infiltration without inflammation all the way to inflammation and scarring that eventually leads to cirrhosis. And without a liver biopsy, which we typically don't get for our patients, we can't really know what our patients have. So that's our NAFLD spectrum. So then thinking about risk factors for NAFLD and why it might be so prevalent in our patient population, the majority of patients with NAFLD and the biggest risk factor for NAFLD is metabolic syndrome and insulin resistance, which is really leading to sort of drive to change the name from this negative definition of non-alcoholic fatty liver disease to a more positive definition of defining what it is rather than what it isn't, which is MAFLD, or metabolic associated fatty liver disease. That hasn't been completely adopted yet. So for this talk, I'm going to keep referring to it as NAFLD with an N, but looking further down the road, it's likely we're going to see a nomenclature change to metabolic associated fatty liver disease. But I think the key thing to highlight here is that metabolic syndrome and insulin resistance are incredibly prevalent in the United States and around the world now, and that is the major risk factor for NAFLD. So we're likely to see more and more of it. And as I said on the last slide, about 25, or in some studies, 20 to 30% of the US population has NAFLD. And in our patients with diabetes who have sort of the end result of insulin resistance, the prevalence of NAFLD is even higher and maybe as high as 50 to 90%. So this is something we should be expecting to see in a lot of our primary care population. And just to think a little bit about how this happens and why insulin resistance is such a driver of NAFLD and why this is becoming so prevalent in our population. This is a very busy slide from a nice review in Nature Medicine that is sort of talking about this theory of the substrate overload theory of NAFLD, but we'll just focus in the left upper corner, which is really focusing on insulin resistance and how it drives NAFLD. And there's sort of three key things that are happening in this picture. And I don't know if you can see my mouse or not, but what is happening is that as people develop insulin resistance, there is sort of increased lipolysis in adipose tissue, which results in increased release of free fatty acids into the bloodstream, which ultimately travel to the liver. And then in conjunction with that, with sort of our Western or standard American diet, we have an increased intake of fats, which end up being free fatty acids in our blood. And we have an increased intake of dietary sugars, specifically a high fructose intake, which in the liver leads to increased de novo lipogenesis, which ultimately also results in increased hepatic free fatty acids. So we sort of have three pathways to increased hepatic free fatty acids, which ultimately build up in the hepatocytes and leads to a lot of negative downstream effects that are detailed on this slide, but sort of broadly leads to increased oxidative stress, derangements in our lipid metabolism, and in the end can lead to NASH and fibrosis in our livers. And so why does all of this matter? Sort of two reasons. If I haven't already sold you on the risk of permanent liver injury and potentially cirrhosis, I think there are sort of two major organs that we have to worry about when we think about why NAFLD matters. One, maybe surprisingly, is the heart and the cardiovascular system, and the second is the liver. And so starting with the heart, maybe surprisingly, cardiovascular disease is actually the #1 cause of death in patients with NAFLD. It's not liver disease. And when you think about that, I mean, if you think about the risk factors for NAFLD, a lot of those overlap with risk factors for cardiovascular disease, so maybe it's not that surprising. And specifically NASH, so inflammation and fibrosis, confers a 2 times higher risk of death from cardiovascular disease compared to the general population. And in fact, sort of looking to the right in this image that's up from a nice New England Journal article, there's some theory that NASH and NAFLD may be independent risk factors for cardiovascular disease in much the same way that end-stage renal disease is an independent risk factor for cardiovascular disease. And this image just sort of goes over some of the theories about how changes in liver endocrine activity may actually be a culprit in increased atherosclerosis in people who have NAFLD and NASH. So take home from that is that NAFLD has pretty significant impacts on cardiovascular risk. And then when we think about the liver, in addition to just your individual patient's risk of developing cirrhosis or significant liver injury, it's actually NASH and NAFLD are becoming a really big public health issue. So in a review of reasons for liver transplantation in adults from 2010 to 2019, NAFLD is increasingly becoming a reason for liver transplantation. So in 2010, it was listed as the reason for about 9% of transplants. And in 2019, it was listed as the reason for 21% of transplants. And in 2019 was actually the leading cause of liver transplant for women in the United States. So it's definitely becoming a big public health issue and something that we should try to recognize early and address early. All right, so hopefully I've convinced you that it matters. Any questions about NAFLD and why it's important? Courtney, is there anything in the chat yet?
There is. There's a question, could the increase in transplantation be part of better control of other causes of cirrhosis?
So there's definitely like some strong theories that part of the reason why it's increasing is that there's increasing treatment of hepatitis C. And so as hep C is declining, there's sort of more transplants that are being done for people with NAFLD, or more people with NAFLD are being able to get transplanted. Yeah. But I think there's certainly an expectation that it's going to become the top reason for transplant within the next like 5 to 10 years.
Izzy, you said that NASH is a pathologic diagnosis, which obviously we don't get very often, but do you stratify people who have hepatic steatosis on imaging and then have elevated transaminases persistently? Like, do you think about those people differently, or could you have the those lab changes even without the actual hepatitis?
So we're going to actually get to how you risk stratify people. There's sort of some ways. There are ways to try to risk stratify like how likely somebody is to have poor outcomes, mainly with indirect ways to estimate degrees of fibrosis. Yeah, rather than doing liver biopsy. And I think my take home is that if somebody has fibrosis, sort of indirect measures of fibrosis, that they probably do have some NASH. But based on what I was reading, some people do actually have NAFLD, not NASH, and some small amount of fibrosis, but it's just much less likely to have fibrosis without NASH.
And another question in the chat, is there a concern for lower supply of donor organs since they may also have NAFLD?
That's a really great question. I didn't read anything about that, but I would guess that yes, that's very possible, especially if we're seeing increasing rates of type 2 diabetes and insulin resistance. Yeah. All right.
All that's in the chat so far.
Okay. Well, let's talk about how we make the diagnosis. And I was just going to pause and ask people, because I'm sure we've all had patients where we think they have NAFLD, how you've made the diagnosis in the past and ways that it's shown up for you. You're welcome to just throw it in the chat or jump on.
There's some votes for usually incidental on imaging, FibroScan, ruling out other things, imaging.
Totally. Great. That's where we're going. Yeah, so I think the common ways that it shows up are either incidentally on labs or incidentally on imaging. There's not really a role recommended yet by the American College of Gastroenterology for screening, mainly because there aren't really effective or there aren't really clinically effective or cost-effective ways to treat it, which we're going to get to later. And so typically either this shows up on labs where people have AST or ALT elevations. And the most common pattern is an AST to ALT ratio of less than 1, compared to, like, if you think about alcoholic fatty liver disease, that's typically seen with an AST to ALT ratio of greater than 2. And then often you aren't seeing elevations of more than about 4 times the upper limit of normal. And if you are seeing really high elevations, like in the high hundreds, it's worth bearing in mind that it is often something different and it is not NAFLD. And then just to note that transaminases are actually not always elevated in NAFLD. And then imaging, sort of incidental findings on imaging is another common thing. So you send them for sort of any other imaging modality, and then it gets read as a liver that seems consistent with hepatic steatosis. And then I think regardless of the type of diagnosis that you get, if it's imaging or labs, looking at the other thing to get confirmation is helpful. So if your labs are abnormal, getting an ultrasound to confirm fatty infiltration, or if your imaging is abnormal, then following up with labs to see how significant your transaminase changes are is helpful. And then just a quick note of warning, according to the American College of Gastroenterology, our reference ranges on AST and ALT actually probably overestimate what's normal. And so they recommend using a lower upper limit of normal than what's typical on our reference ranges. And so they recommend these cutoffs that are on this slide. So some people actually may appear to have normal AST or normal ALTs, but actually may not, according to our